Welcome, everyone, and thank you for joining us on this Thursday evening for the evening's virtual UMiami Health Talk. The title tonight is Putting Your Best Foot Forward, Advances in Restoring Blood Flow for Peripheral Arterial Disease. I'm health journalist Ileana Bravo, and I will be your moderator for tonight's program. Tonight's UMiami Health Talk is presented by UHealth Virtual Clinics. Our UHealth experts are ready to care for you, whether it's in our facilities or virtually, wherever you are. We invite you to learn more about the measures we have in place to keep you safe if you come into our clinics, as well as your appointment scheduling options. Please visit us at umiamihealth.org to see all your options there. Tonight, we're privileged to hear from two internationally known University of Miami Health System vascular surgeons, Dr. Jorge Rey and Dr. Omaida Velasquez. Our expert panelists are going to speak to you on the signs and symptoms of peripheral arterial disease, the latest diagnostic tools, and the latest advances in treatment, including minimally invasive endovascular procedures, vascular surgery, and leading-edge gene and stem cell therapies to restore blood flow in affected limbs. We are going to have a question and answer session directly at the end of the presentations of our experts tonight. Many of you have already submitted your questions in advance, but there's plenty of time to do so throughout this hour, so please do so by using the anonymous Q&A feature at the bottom of your Zoom screen. Take a moment to locate it there. Looks like a little box that says chat, rather Q&A. And that's the one where you're going to enter your questions and we will present them and tee them up for our experts at the end. So let us begin, and I'm pleased to introduce to you our first presenter, Dr. Jorge Rey, who will be sharing his presentation with us shortly. Dr. Rey is an associate professor of surgery in the University of Miami Miller School of Medicine's DeWitt Daughtry Family Department of Surgery. Dr. Rey is chief of the Division of Vascular Surgery and leads a team of vascular surgeons dedicated to preserving patients' lives and limbs through the research and application of innovative, minimally invasive, and vascular surgery approaches. Dr. Rey's presentation tonight will concentrate on an overview of peripheral arterial disease, its diagnosis, and surgical treatments. Dr. Rey, please unmute yourself and take it away tonight.
Thank you, and thank you everyone for being with us at this hour. First, let's try to talk about what is peripheral arterial disease. Peripheral arterial disease is essentially an accumulation of plaque in the walls of the arteries. When plaque is formed and is starting to block the arteries, you can have something that we call atherosclerosis. And that can happen in your legs as well as in the multiple arteries of your body. One of the risk factors, or some of the risk factors of having a PAD, or peripheral artery disease, are advanced age, more than 65 years of age, has a higher incidence in men. When someone has hypertension, has more tendency to have PAD. Definitely one of the main factors that we work on, everyone that comes to our clinics, is smoking. Diabetes, and high cholesterol, hyperlipidemia, and obesity as well. Lack of exercise is another factor that we try to work on in anyone that has PID, and also family history, as well as heart disease or strokes. You can see in the picture how a plaque can look like inside the body when it's formed, and how can this plaque leads to symptoms in your legs. So essentially, symptoms that you can have with PID are pain, sometimes burning sensation or cramping in the legs when you walk or when you exercise, and usually it gets better when you rest. Sometimes in some acute settings, the legs and the feet could be cool to touch. And if you have a wound, can take a little longer to heal. We label a non-healing or a poor healing wound when it takes longer than 4 weeks. When you have PID, or when one had PID and you don't treat it, this can just progress from something that we call claudication, which is pain when you walk, to rest pain, which is pain at all times, as well as at some point you can get to the point where you can have ulcers, tissue loss, and at some point you can have something that is called gangrene, which is sort of the end point of the disease. And eventually, if nothing is done, you can potentially lose your legs. There is a lot of compensatory mechanisms that we have in our body. One of them is the formation of collaterals. Not everybody that has PID needs an operation, but they do need some lifestyle modifications to start. The reason why we do a lifestyle modification is to try to develop these things that you see on the screen, which is formation of arteries or collaterals to be able to compensate for the blockage of the vessels that you may have. The first symptom of PID is claudication, which is usually a pain that is developed or associated with exercise. And depends on the extension of these claudication symptoms. It could be felt as a cramping pain in the calves, and it could be reproduced by every time you walk or walk the same distances. Sometimes you can have the same pain in your buttocks or in your thighs. There is a study, one of the studies that we use is very known and as a work in cardiovascular diseases. It's a Framingham study which was launched in 1948. So they have been following the same population for now almost 70 years. And the study has been followed for multiple generations. And this study has found that within 5 years, if you have PID or you have claudication to start, 5% of those patients can have a major amputation within 5 years. 23% of those patients can have coronary insufficiency, which is blockages in the arteries that feeds the heart. And 13% of those patients can have cerebrovascular incidents such as stroke. 20% of those patients could die within 5 years, not necessarily as a result of PID, but other causes. There is a classification system that we have for PID, which essentially try to divide these patients between the less or the least severe to the most severe. We start by having patients with claudication of less than or more than 200 meters to having claudication or pain more than 200 meters. Then they progress or they can progress to rest pain and lastly, tissue loss. The treatments that we usually suggest to our population are, before we go to medications, is essentially lifestyle modifications, such as smoking cessation, exercise, sometimes diet, and usually we start them in some of the drugs, such as aspirin, statins, etc. Lastly, in some cases, we can recommend an intervention. We try to make sure that we ask the right questions when someone comes to our clinics with PID, such as, can you sleep at night? Is this pain worse at night? It's only worse when you walk, etc. Do you have a wound that is not healing? And have you had any previous interventions? When we do a physical exam, a few of the things that we know that we can find in people with PID are changes in colors. Sometimes if you look at the picture, the foot in the left side is a little red bright compared to the other one. And that's called depending rubor. And as a matter of fact, interestingly, that's the foot that is affected. One of the first symptoms also are loss of hair in the limb or in the extremities, atrophy of the muscles, and loss of the nails or loss of the quality of the nails. Eventually, as I said before, the people can develop ulcerations and tissue loss. When we examine those patients, sometimes you feel weaker pulses or sometimes absent pulses. And we perform some basic studies when someone comes to our clinics, such as doing ankle brachial index. We measure the blood pressure in the leg compared to the arm, which they're supposed to be equal. And if there is a difference, we can say that likely the person have some arterial blockages in the lower extremities, and then we act on it. When you look at the studies that we have available in our office, one of them that we use often are these blood pressure cuffs that we place through the entire lower extremities. and we measure the circulation in every segment of the leg. And when we measure that, we can actually say where the blockage could be, and if it's something that it could be treated with minimally invasive techniques or requires a major reconstruction. This is how the study may look like, and we can interpret it as the bigger waves are more normal, and the flatter waves could be representing a lack of a pressure or lack of good circulation in that segment. So those are the same studies, and you can see in some areas where the waves are a little bit more dampened, and that could represent a decrease of blood flow in that area. So we also can perform ultrasounds in their office, and we can, when someone comes to see us, we can have the studies done at the same time. So we can measure the circulation, measure the blood flow, and also do some imaging studies to see if there is a blockage and then which particular location is the blockage on. You can also order, in some cases, we order CT scan. This is a reconstruction of a CAT scan where we can see more in detail the circulation and see if there is any abnormalities that we can treat. Lastly, when we think that the person did not respond to changes in lifestyles and changes in diet, changes in habits such as smoking, and we're going to intervene, we perform angiographies, which are minimally invasive studies where we can put a needle in the groins and we can inject something that is called IV dye or contrast. By injecting that contrast, we can see the blockages, and we can also treat them at the same time. So when we decide that someone needs an intervention after failing these conservative treatments, then we can try to improve the circulation, starting by improving the inflow, something that we call the inflow, which are the bigger arteries in the lower part of the abdomen. And eventually we may have to open the distal part, which are the arteries that are crossing around the thigh, which are the femoral arteries. And we can start by doing something that is called endovascular interventions. Endovascular interventions are essentially where we can put very fine tools such as wires, and through those wires, we can perform a lot of treatments. So if you look at this slide, you can see how we can do sort of something that looks like a mini drill in which we can remove the plaque, just entering from the groin with a tiny little needle. And we can also put balloons or do angioplasties to sort of open the channel and separate the plaque so the blood can flow properly, and we can improve the circulation and the problem could be resolved. So those are usually our first line of treatments. And when somebody comes with a very advanced disease, then we can try to treat them with a bypass or an open reconstruction. Usually in those cases, sometimes we use the patient's same vein, or we can use some prosthetic materials such as Dacron, etc. Those are essentially the options that we have to treat advanced PID. In conclusion, claudication requires optimal medical therapy. One of the first things that we do is try to change the risk factors for claudication, such as the smoking part and diet, exercise, etc. Tissue loss could be caused by blockages of the blood flow. Sometimes tissue loss is just the tip of the iceberg. You see an ulcer, and the ulcer is just a consequence of a blockage in the blood flow. And there is definitely surgical options that we can try, such as endovascular, which is also always our first line of treatment. You go from the groin, you enter with sheets, wires, and catheters. And if that doesn't work, or somebody requires a bigger intervention, we can always try to do an open intervention. Sometimes we have a combination of both, which is stents in some areas and open procedures in other areas. Those are called hybrid reconstructions. We also have different options that perhaps are not available in many other centers, such as stem cell therapy, and things that are now still in trials, not a standard of care, but Dr. Velasquez will probably explain this and show us what is the latest and what else is coming to treat this condition. Thank you.
Thank you, Dr. Ray. And I remind you now in the audience that it's the perfect time for you to think of those questions that you'd like to ask Dr. Ray or our next presenter, whom I'm about to present, Dr. Velasquez, because all you have to do is go to the Q&A feature at the bottom of your Zoom screen, put the questions in there, and we will tee them up for our presenters. So it's my pleasure now to introduce Dr. Omaida Velasquez, Professor and Chair of the DeWitt Daughtry Family Department of Surgery at the University of Miami Miller School of Medicine. Dr. Velasquez is also the David Kimmelman Endowed Chair in Vascular Surgery at the Miller School and the Surgeon-in-Chief for the University of Miami Health System and Jackson Health System. Dr. Velasquez is an internationally known physician scientist and has conducted breakthrough research on gene and stem cell therapies for vascular applications. Tonight, Dr. Velasquez, as you present your presentation, she is going to speak on gene and stem cell therapies to restore blood flow to ischemic tissues. Dr. Velasquez, welcome.
Thank you, Ileana. I want to talk to you a little bit about what's coming. You heard from Dr. Ray that we have an range of various therapies, whether it's open surgical bypasses or whether it's a simple balloon angioplasty or DAC, an angioplasty combined with a stent, and other hybrid procedures that combine the catheter-based technology with the open technology. And all of that is already in the clinics. And all of that is possible to be applied to patients that have peripheral arterial disease and to help them. But there's also new things that are coming in the horizon. And I'd like to give you a little bit of a glimpse of that. To begin with, I'd like to disclose that the technology that I'm going to share with you a little bit about today has been invented, patented by the University of Miami and licensed by the University of Miami, and it's coming out of the research laboratories of myself and my collaborator, Dr. Zajun Liu. I've also been an investigator in a number of trials that have tested similar technologies in gene and cell therapies that are aiming to basically reform that vascular network that brings the circulation to the leg when the leg is getting in trouble because it doesn't have blood flow. And there's this term that we use, ischemic or ischemia, and it basically means no blood flow, or at least not enough blood flow to supply a healthy muscle tissue and healthy skin. And so these technologies are introducing a new modality beyond catheters, beyond surgical reconstruction, into a simple injection of cells or an injection of a gene therapy that modifies the expression of molecules in the tissue so that it can reform the blood vessels. And you heard from Dr. Ray that what happens is you get these blockages, this interruption of flow through the normal natural vasculature that is bringing circulation to the leg and the foot and the toes. And as a result, you end up with this terrible pain, and people need to sometimes get up in the middle of the night and dangle their feet because their feet are burning, and gravity is helping bring a little bit of that extra blood flow to their feet, and it makes them feel better. And as this progresses, literally the tissue dies, and you get these wounds, this area of skin that has died. And as it progresses even further, you get this situation where the skin mummifies, that we call gangrene. And it's a terrible situation because there's pain, there's decreased quality of life, but also people end up having major events happen, strokes, heart attacks, even death. And you can see here in these curves that if one follows a large group of patients that have peripheral arterial disease, for as long as they can remain stable using lifestyle modifications like not smoking, controlling their diabetes well, doing a lot of walking, maintaining their weight, eating well, taking medications that lower their blood pressure, lower their cholesterol and their lipids. So for as long as they are on optimal medical therapy and with optimal lifestyle choices, and they remain stable, they're in this global population that has peripheral vascular disease and that has a certain incidence of stroke and heart attacks and whatnot, but it's not as bad in 5 years of follow-up. But by the time that people get symptoms, when you start getting that claudication, that cramping that Dr. Ray was talking about when you walk, or even beyond that, the wounds or the gangrene or the breast pain, then you're, that individual is over here in the blue line, the symptomatic one. And you can see that if you look at what we call the event-free survival, it's a real bad disease. Not many people make it beyond the 5 years with a symptomatic peripheral arterial disease. So we got to do something about it. And we see this is another way of looking at the data. This is looking over here at the cumulative incidence of death and of major amputation. And you can see it goes up as soon as you have a person that has had symptomatic peripheral vascular disease. It starts aggressively going up, death and amputation rates. And when you compare the ones in red here, which are the ones that have symptoms in the lower bars, compared to the ones in blue that have no symptoms, the incidence of death and amputation is significantly increased. So we got to do something about this disease when it rears its ugly head and it starts giving people symptoms. So the best advice that we give patients is be aware that this disease is out there, that is very, very common. It's more common than many cancers and more deadly than many cancers. And so when the first symptoms happen, come to a vascular specialist, figure out what's going on, because it's not always going to be horrible, terrible, big surgery. Most of the times it's going to be advice as to what to eat, what type of exercise to do, what things to avoid, and so on and so forth. But if it gets to a procedure, the bulk of patients can be helped with what we call minimally invasive procedures. And we have a variety of tools that you see here, fancy stents and catheters and lasers and balloons. And we can get all the way, this picture here on the far right is an x-ray of a patient with a terrible, terrible set of blockages. And you can see the little squiggly line here is a balloon that has been past all those blockages, all the way out to the heel bone, the calcaneus. So we can do a lot with minimally invasive approaches. And Dr. Ray and our entire vascular team is very facile with these tools. And if those tools are not enough, we can, and you have a person that has a tissue problem that is still compromised, we can add hyperbaric oxygen therapies. And what we do with those therapies is that we induce the body's response to release mother stem cells into circulation. And those mother stem cells come into the tissue that's ischemic, that has not enough blood flow, and allow the tissue to begin to recover and regenerate the needed vasculature. And this is what takes me to the part of my talk that I wanted to introduce you to these new potential cures in the horizon for this terrible disease. And they come in the form of genes and genes and cells. These are tiny things. The genes are basically molecules, and the cells, you're very familiar with what they are, but you can't see any of them. But you can put them in a syringe, and you can introduce them into a leg that has ischemia, that hasn't had enough blood flow. And these genes and cells can actually help allow the tissue to rejuvenate itself, regenerate itself, heal, and form a vasculature. And how do we know that these cells are important? Well, there's a body of growing literature. A great deal of it has come from research labs here at the University of Miami, Dr. Liu, myself, many others across the country. And in this experiment, these cells were labeled blue. And you can see that in a wound that's completely healed, that has been approximated, there's no need to create any tissue. It's just close together and it's gonna heal in 2-3 days. These blue cells are not needed. But in a punch biopsy, a wound that requires filling in with extra tissue, similar to the ones that I showed you at the beginning, the ischemic wounds, these cells are very much needed. And you can see them coming in here into the wound. And the problem is that when the wound has no blood flow, in ischemia, as you can see here, if the wound, if the tissue has enough blood flow, these cells can come in and do their job and heal things up. But if it doesn't, this is what happens here. In an ischemic wound, unfortunately, though these cells are needed, they are unable to come in. And so what we have been working on in the research laboratories in the horizon is using these cells and sometimes just the genes that induced these cells for clinical application in peripheral arterial disease. And we're not the only ones. This is a very timely topic. And if you go on clinicaltrials.gov and you put in the keywords of stem cells for peripheral arterial disease, or this term here, CLI, critical limb ischemia, which is the end stage of the disease where people already have the wounds and the gangrene and the rest pain. You see all these trials are ongoing, looking at different kinds of mother stem cells that can help regenerate the vasculature in these patients. And if you do the same search for gene therapy, and this is direct modification of the proteins in the tissue using gene therapy, you see that there's a number of trials that have been going on now since 1998. And not all of them have been the cure-all. And this is where our laboratory has come in, looking at where we can improve that technology. And I'll share with you just a little bit of what we've done in that arena in a second. We have had a cycle of clinical trials opening at the University of Miami with our vascular group. And every 3 to 6 months, a new one opens. And we allow patients that have no other option, in whom the standard of care hasn't worked well enough for them. We allow them to enroll if they meet the criteria for enrollment. And this was one of the trials that we did, where the bone marrow derived mother stem cells of the patient himself or herself were gathered and injected into the ischemic tissue in the leg. And you can see here the upper curve is the survival, and on the right side, this is the amputation-free survival of the patients that received the cells, compared to the lower curve, which is the amputation-free survival for patients that only got the placebo or the saline, if you will. So clearly, we have very strong level 1 evidence from clinical studies that we can use cells and we can use genes to regenerate a vasculature and save a limb in a patient that is suffering from advanced peripheral vascular disease. But how do we make those cells potent enough? What is the communication that is required at the molecular level and at the genetic level? And this is where our new therapy invented here at the University of Miami comes in. It was based on a discovery from 2016. And the discovery was pretty fundamental. And what it basically allows us to realize is that there's this adhesion molecule on the surface of cells that if you don't have it, if the cell doesn't have it, those cells are unable to form a vasculature. And you can see here on your left of the screen, that's a normal wound with normal E-selectin level. But on the right, this is a wound whose cells have been devoid of E-selectin. And basically the red and wiggly stuff is the circulation of that wound. And you can see how the lack of E-selectin diminishes the ability of that wound to replenish the necessary vascular bed to restore circulation. And you may ask, so, okay, if E-selectin is needed to have a circulation within a healing wound, what is the role of ischemia? What happens in ischemia? Why doesn't the body just recruit the E-selectin? Well, it turns out that instead of recruiting the E-selectin, what happens is that in ischemia, the tissue downregulates the E-selectin. So here you see, these are histology slides that show in the green / yellowish color, this is the E-selectin in a normal limb. It should be there lining the blood vessels. But as soon as that tissue becomes ischemic, loses its normal blood flow, the E-selectin gets significantly down-regulated. And you see here the quantification of those images. And so they're in the advance coming from our laboratory, which is to restore the E-selectin to the ischemic tissue, such as to be able to induce a vascular regeneration and wound healing and resolution of the gangrene and ischemic symptoms. And we have demonstrated here that with the genetic manipulations that we have developed in the laboratory, we can achieve tremendous upregulation of the E-selectin in the tissue that's in trouble. And the other groups that you see here are just the controls that we use, in which we do not see similar upregulation of E-selectin. And what does that do to a limb in a preclinical model? This is a mouse model. What does it do when you upregulate the E-selectin in a ischemic tissue, a ischemic limb? Well, the results are quite remarkable. Here you see the control. This is the foot pad of a mouse. And here you see on the right, the E-selectin gene therapy treated foot pad. And you can see all of the red little wiggles are that circulation that has been restored to that compromised ischemic limb. And on your right-hand side, you see here the quantification, the number of capillaries in that limb that was treated with the E-selectin gene vector is significantly increased. So you may ask, so what does that do to an actual physiologic life form? And you can see it here in this preclinical mouse model. On the right side is the mouse that is running the treadmill that has been treated with the E-selectin. And what has happened is that the skeletal muscle of that limb was able to heal, regenerate the vasculature, and can exhibit much higher endurance in the running treadmill test than the control animal. To summarize several years of important research that has come out of the University of Miami, let me sort of show you here. Basically, what we know is that there is a need for E-selectin to be restored at the level of the cell surface within tissue that is suffering from ischemia, particularly limbs in the skeletal muscle and in the skin. And if we do that, we can decrease the amount of gangrene that results after the insult of the ischemia event. We can increase the perfusion, the vessel density, the amount of circulation going to that limb. We can decrease the atrophy of that muscle as that would happen as a result of the ischemia, and we can increase the running distance. And we believe all of these physiologic endpoints are extremely important and applicable to peripheral arterial disease. And this technology really offers promise of something better than or in addition to the plumbing that we typically offer clinically these days. And that, don't get me wrong, that plumbing is extremely important. Without that bypass, without angioplasty, without that stent, many more people would lose their legs from peripheral vascular disease. But if we are able to add cell-based and gene-based therapies, that would be a tremendous leap forward, potentially even a cure. And the E-selectin platform offers that promise. So it will be given as an intramuscular injection in the affected limb. And a number of individuals have been very excited about this potential technology for the future, and have invested in it based on the intellectual property and patents that came out of the University of Miami from the Vascular Research Laboratories. And a startup company based out of the University of Miami named Ambulero Inc. was formed, and now has an international collaborator that has invested significantly in helping us evaluate this technology in human beings. And the timeline is anticipated to be about a year to complete the FDA prerequisite studies so that we can then do the first in men clinical trial about a year from now. Uh, I would like to close by acknowledging the many brilliant minds that have worked on this project for the last decade or so. Our sources of funding, which include the Kimmelman Foundation, the National Institute of Health, and the Coulter Center. And a special thanks to so many of our generous donors that have made this research possible. In particularly the Eloise Kimmelman Foundation has transformed our ability to do limb salvage research here at the University of Miami for the last 15 years. And some very generous benefactors have added to those resources. So a special thanks to the Chamorro family and the Boich and Ceburias family and to Lynn Hutton. And with that, I will conclude my remarks and give us time for the Q&A.
Thank you. Perfect. And we have about 25 minutes or so to be able to tackle these questions. Some have continued to come in through the live chat area, and we have a few ready to go. So I think this one is probably going to be good for Dr. Ray. We'll begin with, are pain and swelling in the legs always an indication of PAD, or could it be something else?
Usually when you have pain in the legs, could be many other reasons. You can have pain in the legs because you have a blood clot, because you have a muscular problem, because you have a tendon problem. In terms of swelling in the legs, is more associated with veins than with PAD. Although there's exceptions to it, but for the most part, you can almost generalize saying that a leg that is only swollen without any pain, without any discomfort, usually is not PAD. It's usually associated with some different conditions.
And Dr. Velasquez, you want to weigh in on that as well, or?
Yes, usually swelling is from being unable to bring the fluid back to the heart, and those vessels are veins and lymphatics. Whereas peripheral arterial disease is a problem of being able to bring the blood flow to the foot coming from the heart. And that typically doesn't cause swelling. The problem is when a person's having pain, it's difficult to tease out those two. And many people have combined venous and arterial disease. So a general rule of thumb is if a person's having pain with walking, or if a wound is not clearing in its usual normal quick time, seek a vascular specialist.
And that's why we're getting bombarded with questions about that little confusion leading to this question is, are PAD and neuropathy the same condition? What's the relationship between PAD and neuropathy?
Now, you can have PAD and neuropathy. They're not the same condition. Now, the problem is you can have also numbness and some neurological symptoms with PAD. That doesn't mean are the same condition. It's just sometimes people with diabetes, for example, can have neuropathy, but it can also have PAD. So the short answer is they're not the same condition, but sometimes the symptoms can overlap.
There is a common foe on both neuropathy and PAD, and the name was mentioned by Dr. Ray, is diabetes. Diabetes basically puts too much sugar in the bloodstream, and some of those sugars attach to the normal hemoglobin that carries oxygen. And there is an important molecule that everyone that has a history of vascular disease, personally or family member, and everyone that has diabetes should be asking their doctor. They should say, what is my hemoglobin A1C? And that number should be below 6.5. And if the hemoglobin A1C is above 6.5, that is oftentimes an indication that there is a problem with diabetes or prediabetes. And typically it is those patients that have both neuropathy and a very high risk of peripheral arterial disease.
So that chronic health condition goes hand in hand in many cases with this.
It does.
This is a very specific question from a patient, obviously participant, who says, I have venous insufficiency due to DVTS caused by a form of vasculitis secondary to blood cancer a few years ago. The cancer is under control now, but the aftermath of the cryo episodes remains. Are there any treatment options that may improve that situation for me? Very specific question.
Yeah, so usually most of the malignancies, cancers or blood cancer, etc., usually make the person prone to blood clots. Cancers or this type of disorders can make one, we call it hypercoagulable or more prone to blood clots. And it depends on the condition. Someone could be a candidate for being anticoagulated for life. I wouldn't answer this generically. I think this is a case-by-case basis. I'll probably like to perhaps see the person in consultation and look at a particular case, perhaps do a duplex ultrasound and see what we're talking about. But the person may benefit from blood thinners. But once again, that's not a generic answer. It's just in some cases, and you have to just examine the patient and see a duplex ultrasound and some other things to be able to make a decision like that.
This question is one that I know that Dr. Ray took a look at in the Q&A session. If there is a family history of aneurysm, does that also place one at higher risk of PAD?
No, the short answer is no. But there is a risk for aneurysms that are also risks for a PAD. For example, if you're a smoker, you have a higher risk of developing an infrarenal aneurysm, and you also have a high risk for developing PAD, which doesn't mean if you have a family history of an aneurysm, you're going to have PAD. Those are not directly related.
Similar to diabetes being the link to both neuropathy conditions as well as peripheral arterial disease, there is a umbrella disease called atherosclerosis, which is an inflammation of the wall of the arteries. And it is that same underlying umbrella disease that predisposes patients to get peripheral arterial disease and get aneurysms. But we do not know why some patients get one or the other. Most patients do not get both. Occasionally, people are unlucky, and there's a small subset of patients that actually get both. They get the peripheral arterial disease, and they get the aneurysmal disease. But if a person has atherosclerosis, they need to be aware of these vascular problems, both aneurysmal disease as well as peripheral arterial disease. How does a person know that they have atherosclerosis? Where typically they might have a family history of high cholesterol, they might have a history of smoking, they might have a history of diabetes, they might have been diagnosed with strokes, mini strokes, heart attacks, mini heart attacks. All of those diseases are related to atherosclerosis.
Question, I have PAD in my feet and have balance issues, so I'm using a walker. Will treatment help with my balance also?
It depends. If the balance issues are secondary to a nerve problem, likely it's not going to help. But if the balance issues are secondary to weakness in the legs because of the PAD, or secondary to pain in the legs because of the PAD, so the answer is yes, it will help. But if it's secondary to something that is not necessarily associated to PAD, I'm not sure if it's going to help.
All right, here's another question. How do you treat ischemia without runoff?
Usually, I'll say people that has been labeled without runoff in my practice, 90% or 95% have some sort of runoff. There's a lot of experience that is needed to be able to say, I can do this type of reconstruction in a tiny little microscopic vessel that has 1 or 2 millimeters in diameter. For some people, that is not considered a runoff. For us, it is considered a runoff. So we can do reconstructions to arteries that are only treated under very significant magnification. But for some other specialists in some other areas that don't have experience in this type of reconstructions, they may call this no runoff. I don't know if I was clear in the answer. So for the most part, people that has been labeled as no runoff, we find a runoff. So it could be reconstructible.
And that is why it's so important to really sort of not give up on this disease. If somebody says there's no options, you need an amputation, get a second opinion. Dr. Ray is an expert in this very, very, we call them far, far aways or distal revascularizations, where he finds a small vessel in the foot or the arch of the foot, sometimes even the toes, and he will find a runoff to recreate the needed bypass. And in addition, if a person truly doesn't have runoff, again, they may be a candidate for gene therapy or stem cell therapy. Like I said, there is a pipeline of these technologies that are coming to clinical testing that might be available to those patients.
Dr. Velasquez, while we have you, let's talk stem cell therapy. Is stem cell therapy with E-selectin available now, or is it only offered in clinical trials? And also, how do I find out more information about clinical trials? Obviously, we figured that would be a question tonight.
Thank you. Yes. So tonight you're really getting the very, very latest, the breaking news in the arena of gene and cell therapy for this disease. And that breaking news is E-selectin. So there are no active open clinical trials yet. We hope that by leveraging the investments of Ambulero Inc. and the generous help from grateful patients and donors that want to see a cure come to the clinic, that we will complete the FDA prerequisite work in the preclinical setting within a year. So the timeline that we anticipate is in about a year, there should be a clinical trial for first in men testing of this technology.
And I just remind everyone in the audience tonight that we have contact information coming up at the very end of this talk so that you know how to reach them directly by email and phone numbers and and even some more specific numbers to get to that, because obviously if you're interested, you'll have to run it by their expert team and they'll see if you're candidates or not. So here is another question, Dr. Ray, maybe you can take this. I have CML for 21 years and leukemia meds have caused claudication, DVT, along with 4 stents and 3 repairs. Very specific clinical info here. Will any of these newer methods help?
It depends. I mean, as I said before, every case is different. When you have someone has leukemia and has had these multiple blood clots and treatments, is telling me that probably has a hypercoagulable condition. The first thing is to keep I don't know if the leukemia is treated and is in remission, or is something that is still active. If it's still active, the person is hypercoagulable. So every time you do a stent or some sort of treatment that is endovascular, it has a shorter lifespan than when someone doesn't have this type of conditions. So sometimes the best, smartest solution is to treat them with medical medications or medical treatments as opposed to do an intervention for this type of problem.
Dr. Velasquez, this questioner says, I've had deep vein thrombosis for over 20 years. Can stem cell therapy cure DVT?
We do not have a strong indication that stem cell therapy can enhance the venous system. So the veins are bringing blood flow from the toes all the way up back to the heart. And that's a different highway than the arteries that are bringing blood flow from the heart down to the toes. And right now, we do not have indication that the stem cell therapies that we're developing would be applicable to enhancing the venous system.
And along the lines of stem cell, let's talk about how UHealth ranks in this in the panorama worldwide. This questioner, who obviously has good knowledge of the subject, says, are you familiar with cardiac stem cell work and related from MD PhD Kenneth Randall Shen now at the Karolinska Institute in Sweden, because your work with stem cells being also cardiovascular, is there any relationship to that research as well, or anything similar?
So the University of Miami has the Interdisciplinary Stem Cells Center and Institute, the ISCI, under the direction of Dr. Josh Hare, who is a world-renowned cardiologist. And he has a significant enterprise in both preclinical and clinical testing for stem cells applied to cardiac regeneration and regeneration of the cardiac vasculature. And the work in that arena is related, but not quite the same, because the cells that are needed to regenerate the muscle of the heart and to regenerate the coronary arteries, which is the circulation of the heart, are different than the cells and molecules and genes that are needed to do the same in the foot and the leg. So it is related work, but it's a bit different. However, in the world stage of stem cell therapies, clearly carries significant currency through the Interdisciplinary Stem Cell Institute and to the work that is happening in our vascular research laboratories.
And Dr. Ray, perhaps one final question, and then I'll ask you both to wrap it and sum it up with your comments. And that is that perhaps people hearing this get concerned and frightened that their symptoms are in fact something like this that is much more serious. Could neurological symptoms, perhaps from spinal stenosis, lower back pain, and other issues like that, mimic and confuse a patient thinking that they might have PAD or something like this?
It's a great question, actually, because one of the most common things that I see when someone comes for PAD is spinal stenosis, sciatic pain, neuropathic pain, etc. And all we do is just do a physical exam and do a quick non-invasive vascular studies to make sure that what she has or what they have is not really vascular related. One of the symptoms or the tricks and the history that we can use is usually vascular problems tend to be worse when someone walks. So if you walk, you have more pain and you have to stop. Sometimes the spine pain tend to get a little better when someone walks a little bit. And that's one of the things that we use, but not necessarily applies in all the cases. But yes, that's a very common question. We have a lot of patients that come to us with either a herniated disc, scoliosis, etc. Have pain in one leg, but usually that pain radiates from the buttocks all the way down to the foot. It's more shooting, burning, that type of thing. This one is more like a crampy pain in the calf when you have claudication.
Yeah. And we see the opposite presentations also. We see the presentations where a person comes in late in the manifestations of their peripheral vascular disease because they've been told it's only sciatica or it's only lumbosacral spine disease, and they've sort of even had back surgery for it, and when the pain doesn't go away, then someone realizes that there's a suspicion for additional vascular disease. So interestingly enough, there is quite a bit of an overlap sometimes in the patient pool that presents with degenerative disc disease and peripheral vascular disease. And it has to do with the age, and it has to do with the risk factors, smoking, diabetes, hypercholesterolemia, family history of peripheral vascular disease. So I think I completely agree with Dr. Ray. I think that oftentimes the person comes in with pain and we can give them the good news that is not the more lethal situation, which is the more serious situation, which is bad peripheral vascular disease. But it's important to get checked if there's in suspicion by the part of their primary care doctor or their cardiologist or even their orthopedist or spine specialist.
And Dr. Ray, I'll ask you to have the last word along those lines. Dr. Velasquez wrapped it up so nicely. This is obviously a serious problem just from the tune-in and the interest tonight for this talk. So send us with a take-home message for what people should listen to and pay attention to.
Well, if I have to choose one, is the most common associated risk factor for atherosclerosis is smoking. So first thing is please don't smoke. Please try to have a healthy habit of at least just walk 30 minutes a day, 5 days of the week. And atherosclerosis, PID, is a systemic disease. So if you have it in your legs, you can have it in your heart and the arteries that feed your brain. So it's a risky thing. And take it seriously. I mean, if you are able to change those habits like smoking cessation, walk, try to just keep a balanced diet, and nobody should suffer and die from this. I think everything could be controlled just with changing of the regular habits.
Well, we cannot thank you enough for the generosity of your time tonight, Dr. Jorge Rey, Dr. Omaida Velasquez. You were wonderful, helped so many people tonight, and thank all of you in our audience tonight for tuning in on this Thursday evening. We at the University of Miami Health System appreciate you. We're here to care for you at the end of the day. And if you have clinical inquiries, questions, please call our vascular surgery clinic administrator at 243-8272 option 0. And to make an appointment, as you see on your screen, it's 305-243-0783. They are there for you, in-person consultations, virtual clinic, however you want, however you need to be seen or heard at this point. And you can also go to umiamihealth.org for more information and to get yourself even further educated. We hope you enjoyed this tonight. Please complete the survey at the end of the talk. We'd love to hear your feedback for other topics you'd like to be interested in the future. So meantime, good night, Dr. Rey. Good night, Dr. Velasquez. Good night to all of you. Please be safe out there and stay well.